Okay, I think we're ready to start. Thank you everyone for taking the time out of your evenings to listen in on our discussion today about prostate cancer screening. My name is Paul O. I'm a resident physician in the field of urology at the Glickman Urological and Kidney Institute here at the Cleveland Clinic. And today we'll be learning from two of our renowned experts in urologic cancers, both of whom I've actually had the privilege of learning from during my own training here. So I'll start with Dr. Schwen. He's going to talk later in the session today, but Dr. Ziad Schwen is an assistant professor here at the Cleveland Clinic. He received his MD at the University of Pittsburgh School of Medicine for his residency training at Johns Hopkins University. And then he actually underwent further subspecialty training here at Cleveland Clinic in advanced robotics. And so Dr. Schwen has helped the Cleveland Clinic pioneer novel surgical techniques for prostate cancer, utilizing a lot of cutting edge robotics advancements. He's also published extensively in major urologic journals, and he's going to provide us a wealth of information tonight. Our first panelist speaker who will be talking to us this evening is Dr. Robert Abuasli. Dr. Abuasli is the director of urology at Fairview Hospital in the Western region here at the Cleveland Clinic. He received his MD at McGill University in Montreal, Canada, and completed his urologic training, residency training at the Cleveland Clinic. He also subsequently underwent subspecialty training in urologic cancer and also obtained a master's in clinical epidemiology at the University of Toronto. Dr. Abuasli serves on multiple professional committees, reviews articles of prestigious journals such as the Journal of Urology and European Urology, and has authored over a combined 100 articles and book chapters in the field of urology, all this while maintaining a very busy, successful surgical practice. So please write any questions you have in the chat box down below. We will address questions after the conclusion of Dr. Schwen and Dr. Abuasli's presentations. Thank you for your time. So let's get started.
Thank you, Paul, for that introduction. I'm going to go ahead and share my screen so that everyone can see my presentation. And just a reminder that this presentation will be recorded and emailed to everyone who registered for the meeting. And like Dr. O said, we'll be discussing questions and answering questions later in the talk. So first, I thought I would talk about what the prostate is, and you can see here that the prostate is a walnut-sized organ that is located under the bladder and under the urethra as well. So it's in the pelvis, and the location, the tricky location, makes it difficult to treat, which is we may discuss later with respect to treatment of prostate cancer. But you can see that it's a little difficult to access. Okay, and with respect to the prostate, as I mentioned, it can be examined on the rectal examination, especially the back side of it. Its role is really in reproduction. It contributes to the ejaculate and provides nutrient to sperm. And so after reproductive age, it doesn't serve much of a useful purpose. Prostate cancer is the most common cancer in the United States, with an estimated 164,000 new cases diagnosed every year in the United States, and is the second most common cause of cancer death among men. A man's lifetime risk of being diagnosed with prostate cancer is estimated to be 16.7%. With the chance of dying of prostate cancer being 2.6%. So as you can see, you're more likely to die with prostate cancer rather than of prostate cancer, because most prostate cancers tend to be slow growing and indolent, although there is a subset which can be quite aggressive. And you can see here that when prostate cancer has spread outside of the pelvis, the chance of surviving at 5 years decreases to about 30%. Whereas if you can catch it in the early stages, the cure rates or surviving 5 years, approaches 100%. So that is the rationale behind screening and early detection. Here you can see the trend of prostate cancer death over the last 100 years or so. And you can see that the risk of prostate cancer death, which is here in pink, was relatively stable. And then right around early 1990, when PSA was introduced, you can see that there was a gradual decrease in prostate cancer mortality. And at least 2/3 of that is thought to be due to prostate cancer screening, with the other third likely due to improved treatments for prostate cancer that we've developed over the last few decades. So PSA, which is the main screening tool for prostate cancer, which was originally used to detect recurrence after prostate cancer treatment. So it's a very good tumor marker. So if you remove the prostate and the PSA is not zero, then there's a suspicion that there may be some cancer somewhere in the patient's body. That being so, but it's also elevated in BPH and inflammation of the prostate or prostatitis. In the early 1990s, it began to be adopted as a widespread screening test for prostate cancer. And in 2009, two large randomized studies published in the New England Journal of Medicine examined the effect of screening on the men's risk of dying of prostate cancer. And in the European study, they showed that men who were screened for prostate cancer had approximately 23% lower risk of dying of prostate cancer over time. So clearly there was a benefit to prostate cancer screening. So why is there any debate as to the benefit of prostate cancer screening if there's an improvement in the risk of dying of prostate cancer? Well, screening does have some downsides. One, not everyone with an elevated PSA has prostate cancer, which would be a false positive. What this means is that the man may have to undergo biopsy or additional testing, as well as the anxiety. And so there is some cost to prostate cancer screening in that way. Also, we may be detecting prostate cancers that otherwise would not have affected the man during their lifetime. So this is thought to be like an over detection. We know in autopsy studies that a large proportion of men will develop small amounts of slow growing prostate cancer as they get older, and that most of these men will die with prostate cancer rather than because of the prostate cancer spread. And so we may be detecting prostate cancers that we really don't want to. Also, we may be treating these cancers and the associated side effects of treatment, especially the effects on urinary continence, erectile function, and bowel function with respect to radiation. Also, there's the associated effect of being labeled as having cancer, the cost associated with the diagnosis and treatment, as well as the anxiety and psychological stressors associated with the diagnosis. Also, the biopsy itself has some risks. The traditional risk of having an infection after prostate biopsy is anywhere from 1 to 3%, but we know that in recent years, mostly due to the emergence of Cipro-resistant bacteria and other antibiotic-resistant bacteria, that the risk of sepsis or infection after biopsy has increased. And so again, there's some risk to doing the biopsy, and Dr. Schwinn will likely talk about the newer approaches to biopsy which decrease that risk. So in the end, you have to weigh the risks and benefits of screening to determine if screening is of benefit to the individual person. The US Preventative Task Force, up until a few years ago, did not recommend routine screening in men for prostate cancer, but recently reversed their decision. And their recommendation is that for men aged 55 to 69, the decision to undergo periodic PSA-based screening for prostate cancer should be an individual one, and that should involve a discussion between their provider and the man about the pros and cons and whether they should proceed. The American Cancer Society says that men should, again, make an informed decision about screening, that they should usually begin at age 50, but can begin sooner, 40 to 45 for men at high risk. So that would be either men with first-degree relatives who had prostate cancer or African-American men. And the screening typically would involve PSA screening with or without digital rectal examination. And if the PSA is low, less than 2.5, they suggest perhaps not doing the PSA every year, but perhaps every 2 years. The American Urological Association, for their part, also has similar recommendations. Again, age 55 to 69, shared decision-making on whether to proceed with PSA screening based on the man's values and preferences, and that the interval of screening can be individualized based on the baseline PSA. And they do not recommend screening under the age of 40 and can consider screening men 40 to 55 if they have a family history or African American race or other significant risk factors. And they do not recommend screening routinely in men over 70 or those with a life expectancy less than 10 to 15 years. So what are the risk factors for prostate cancer? And we don't consider screening in isolation or PSA values in isolation. We put it in the context of the patient. So we look at family history, age, race, diet, and these are all the factors we take into account when we either consider screening or interpreting PSA results to decide if we're going to proceed with biopsy. As a screening tool, the digital rectal examination is not great in terms of detecting prostate cancer because in order to detect it, it has to be big enough to be able to be felt with your finger. And so it is not very sensitive at detecting prostate cancer. So studies have suggested a sensitivity of about 28%. That being said, when the rectal examination is abnormal and suspicious, the chance of prostate cancer tends to be pretty high. So again, we use PSA for screening. What is PSA itself? It's actually a protein, and it's found in the cells, the epithelial cells of the prostate, and only the prostate. So it's very specific for prostate tissue, but not specific for prostate cancer because there are other conditions of the prostate which can cause increases in PSA, such as BPH, which is enlargement of the prostate with age, prostatitis, which is inflammation, prostate manipulation, such as a prostatic massage or resection of the prostate surgically, or inability to urinate, so urinary retention. All of these factors can increase PSA. So what other tools do we have available other than PSA to try to determine a man's risk of prostate cancer? Well, free PSA was developed many years ago. And we know that a certain percentage of PSA is bound to protein in the blood and a certain percentage is free floating. And the lower the percent free, the higher your risk of prostate cancer. And again, a study in the mid-90s showed that in men with PSAs of 4 to 10, if your PSA free is less than 10%, there's concern for prostate cancer. Greater than 20, it's more consistent with BPH, which is benign enlargement of the prostate, and that there's a 10 to 20%, which is more of a gray zone and doesn't really help you much in your decision making. So again, when we see men with elevated PSA, we try not to take the PSA alone into account, but we also try to include all the information. So there are risk calculators that were developed that help us synthesize all the patient's clinical information to determine their risk of prostate cancer. One that is commonly used is the Pcpt risk calculator. And here, for example, if you plug in data like a Caucasian man who's 58 with a PSA of 5.8, with no family history and a normal examination, never had a biopsy, and a percent free of 21%. So their risk of high-grade prostate cancer is only 4%, and the chance of having low-grade cancer is 14%. So this information can be important in counseling a man about their risk and whether we should proceed with biopsy. And studies have looked at how accurate these risk calculators are in predicting the man's risk of prostate cancer. And we use information called the AUC, or area under the curve. So the higher this number, closer to 1. So if it was a 1.0, that would be perfect prediction. So it's always accurate. If it's 0.5, it's basically a coin toss, 50-50 of whether the test is accurate. So the higher the number, the better. And you can see that there's a little bit of variability in how accurate these calculators are. So what else can we do to try to assess the man's risk of prostate cancer? Well, there have been a number of prostate biomarkers that have become available over the last several years, which again help us assess the risk. One, which you may have heard of, is the 4K score. It is a prostate-derived kallikrein proteins, and they combine this data with clinical characteristics, the examination, and prior biopsy status to predict the a man's risk of having Gleason 7 or greater prostate cancer. And that is what we consider clinically significant prostate cancer. The Gleason 6 prostate cancers, or now we call them grade 1 prostate cancers, we tend not to treat, and those are the ones we tend to observe on active surveillance. So when we talk about clinically significant, we usually mean grade 2 or higher, or Gleason 7 or higher. So again, the 4K score uses a cutoff of 9%, and if you do that, you can reduce unnecessary biopsies by about 43%, with only delaying the diagnosis of prostate cancer in 2.4% of men. But this test is affected by the digital rectal examination, so you cannot do this test for 96 hours after a digital rectal examination, and is not accurate also in men taking 5-alpha reductase inhibitors such as finasteride or dutasteride, or if they've had a recent BPH procedure for enlarged prostate. The Prostate Health Index is another test. It looks at levels of free PSA, total PSA, and pro PSA, and puts it into a formula to predict your risk of Gleason 7 prostate cancer. It's intended for men with age greater than 50 with serum PSA 4 to 10. That's how it was developed, and a negative digital rectal examination. And basically, the higher your prostate health index score, the higher your risk of prostate cancer, such that if your score is greater than 55, your risk of prostate cancer is about 50%. And then, of course, there's ISO-PSA, which was developed here at the Cleveland Clinic, and this is the one we use the most. This is a blood-based structure-focused assay, so it looks not only at a few isoforms of PSA, but looks at all the isoforms of PSA, and then assesses the man's risk of prostate cancer. Again, the area under the curve is fairly good at 0.78, so again, close to 1. For high-grade prostate cancer, and again, reduces unnecessary biopsies by 43%, which is important because of the risks of the biopsy and the discomfort associated with it. And if you add MRI to the ISO-PSA, which we'll discuss in a few slides, the area under the curve is 0.83, which is even better. So it's a better predictor of significant prostate cancer. So what else can we do to stratify a man's risk of prostate cancer, which I just mentioned? Of course, the MRI, and that's the other tool we use a lot in addition to the PSA to assess and risk stratify men to determine if we're going to proceed with biopsy. So traditionally, we have not had great visualization of the prostate. The ultrasound was the tool we used to use, which helps us identify the prostate itself, but for the most part does not visualize the cancer very well. But several years ago, a couple decades ago now, MRI became more and more popular because it allows us to look at the prostate in detail and the specific zones of the prostate. For example, the peripheral zone, which is the part where 70% of the cancers are found. But also the anterior zone is an area that was difficult to reach on the traditional transrectal biopsy. And this test, the MRI, allows us to identify cancers in that area and therefore allows us to target it better. And Dr. Schwinn, I'm sure, will discuss the different approaches for targeting during a biopsy. So here you can see an MRI showing the prostate with the different zones, the peripheral zone, the transitional zone, and here you can see the bladder. And we know studies have shown that targeting MRI lesions increases the chance of finding clinically significant prostate cancer, but decreases the chances of being diagnosed with insignificant or low-grade prostate cancers. So how do we approach screening at the Cleveland Clinic? Well, for the most part, when a man is screened for prostate cancer with PSA and they have a concerning PSA, especially if it's over 4, we tend to order the ISO-PSA. If the ISO-PSA is negative, then we can consider just monitoring the man with a repeat PSA in a few months, again, just to make sure that it's not a false negative. But if the ISO-PSA is positive, then we would order an MRI. And if the MRI is negative, then they would have a traditional biopsy where we would sample several areas of the prostate. But if the MRI shows a lesion, then we would include a fusion, what we call a fusion targeted biopsy, where we use the information from the MRI to help the biopsy be more accurate. So this is the traditional approach. And so using the information from the ISO-PSA and the MRI, we can determine who needs a biopsy. And in general, when the man's risk of prostate cancer is less than 5%, we don't recommend a biopsy. If it's greater than 15%, then we do recommend a biopsy. And if it's 5 to 15, then we consider it and we discuss the pros and cons. And this is unpublished data that we just looked at. So if a man has a low ISO-PSA and a low risk MRI, so there's no suspicious lesions, their risk of prostate cancer is low at 4.2%, so they may not need a biopsy at all. Low PSA with an intermediate risk lesion, again, very low risk, probably don't need a biopsy. But if the ISO-PSA is elevated despite a negative MRI, the risk is 8.2%, and so they may want to at least consider a biopsy. And then you can see that the risk increases, so that if you have a high ISO-PSA and you have a suspicious lesion on the MRI, your risk of prostate cancer is about 50%. So these are men for sure that we would proceed with biopsy. So that concludes my portion of the presentation. I will give this back. I'll stop sharing and give back. Thank you so much for your attention.
That was excellent. Nice work. I'll share my screen here. And yeah, thank you everyone for joining. All right. So we're going to talk about prostate cancer diagnosis. Is everyone able to, Rob, are you able to see my screen here?
Yes.
Great. Just want to confirm. Yeah, so my name is Dr. Schwen. I specialize in also urologic oncology and also robotic surgery. I'm primarily at the main campus in Hillcrest Hospital. And so let's talk prostate cancer diagnosis. How do you diagnose it? Not through a PSA or an MRI or any imaging test, not through a finger exam, but you need a tissue diagnosis. So that means a prostate biopsy. And that's how 99% of prostate cancers are diagnosed. There's the rare instance where you get a prostate opening procedure like a TURP, and they can sometimes accidentally find prostate cancer that way. But the prostate biopsy is the most common way. And there's two types of prostate biopsies. The two most common type, well, the most common type that's being done now is called the transrectal prostate biopsy. That's where the ultrasound probe goes through the rectum and the needle goes through the ultrasound probe through the rectal wall and into the prostate. And there's another type of prostate biopsy called the transperineal prostate biopsy. And that's the same type of ultrasound probe that goes into the rectum. That's the best way to see and visualize the prostate. But the needle goes through the skin into the prostate and does not go through the rectum. They're well tolerated in the clinic. Most of the time, people don't need to be put asleep. 99% of patients just need the lidocaine to help numb up the skin in the prostate. We also offer nitrous oxide sedation. It's like laughing gas like you would get in the dentist's office. And that's good for some folks. It's safe, low risk of an infection. You may need antibiotics, minimal risk of bleeding. So it's safe from that standpoint as well. And this is a common question we get. There's no risk of spreading cancer with a biopsy. So it's safe from a cancer standpoint to sample the prostate. There's a common type of fusion biopsy that we will do. And that really means when someone has an MRI that's suspicious for prostate cancer, and there's an area of suspicion, we can actually have the ultrasound and the MRI fused together in real time. So using the ultrasound, we can actually target the area that's found on the MRI. So that's called a fusion biopsy, and that's something that can be done both the transrectal approach as well as the transperineal approach. It allows us to better target suspicious areas and get a better sampling of the suspicious area. Before the biopsy, it's always important to hold the blood thinners. Some urologists are okay with aspirin, but some are not, so make sure you ask if you do have a biopsy. No bowel preparation is needed, although a bowel movement before the biopsy is a good idea. I recommend a driver, but it's not necessary for most people. And also before the biopsy, eating something in the morning and being hydrated, because that's something that can make you a little dizzy if you haven't had anything to eat or drink. We sometimes, on the day of the biopsy, give antibiotics. Always for a transrectal biopsy, everyone will need antibiotics, and only sometimes for the transperineal biopsy. And we'll talk a little bit more why. The ultrasound probe is inserted into the rectum. The prostate or the skin is numbed up with lidocaine, and biopsies are taken from areas of the prostate that are commonly harboring prostate cancer, and as well as other areas in the targeted spots. So you can get between 12 to 16 prostate biopsy cores. I know that sounds like a lot, but that's the standard way to make sure we sample the entire prostate. Positioning. For the transrectal approach, most people are on their side on a bed, and the ultrasound probe is inserted when your knees are kind of up to your chest. For the transperineal approach, it's actually when you're on your back and your legs are up in stirrups. That's the best way to get access to that skin. Who needs a prostate biopsy? Well, we look at a lot of things. We look at your PSA, other blood test biomarkers that could be elevated, like the ISO-PSA, the PHI, the 4K, or the PCA3 that Dr. Abuasli was just talking about. Also, we look at your imaging. The MRI is the most common. CT scans are not very good at seeing prostate cancer. Ultrasound is not very good. There's a type of ultrasound called a micro ultrasound, which is a little bit better, but the MRI is usually the most common. Also, if you have a high risk calculator, and that's another thing that Dr. Abuasli was talking about, of who needs a biopsy. We look at other risk factors like family history as well as your rectal exam. A few cutoffs that we look at, well, PSAs that are above 3 to 4, a concerning rate of the rise. So if your PSA is rising quickly, that's another reason to potentially consider a biopsy. A suspicious lesion on the MRI, a high PSA density, which is when you divide your PSA by the size of your prostate, which would be something that it could be elevated in men with a higher density of PSA relative to the size of their prostate. Also, a concerning digital rectal exam, like if there's a firm spot on the rectal exam. PSA density, like I just mentioned, you can calculate it, which is a pretty accurate way to find out a risk of prostate cancer. And that's when you divide your PSA by the prostate volume, because large prostates make more PSA. So you want to account for that. And so that's a really effective way of identifying if your PSA is elevated because you have a large prostate, or if it's elevated because you have a concern for prostate cancer. Generally speaking, we like to get an MRI before the biopsy. There's a lot of evidence that has come out, a lot of large studies that show that getting a prostate MRI before a prostate biopsy is a good idea because it increases your cancer detection. If there's a suspicious lesion, you can do a fusion biopsy. And also in some select people, if the MRI is normal and other markers like your PSA density is low, you could potentially avoid a biopsy. Or if like your ISO-PSA is low, like Dr. Abuasli was showing that data, that it's a low risk when combined with other lower risk imaging. But an MRI, like I said, is not perfect by itself. A negative MRI does not mean you don't have a chance of having prostate cancer. In fact, MRIs will miss about 10 to 15% of clinically significant prostate cancers. So we still typically will recommend a prostate biopsy. There's a few select cases where we may consider not doing it, but that's something that you would discuss with your urologist. So let's talk a little bit about the transperineal prostate biopsy. This is a little bit on the cutting edge of kind of what we are now offering here at the Cleveland Clinic, as well as other centers around the country. And that's because transperineal prostate biopsy, when you think about it, when I talk to my patients about, not having to put the needle through the rectum into the prostate, well, they say no crap. Well, it's a lot safer to put it through the skin into the prostate. And the way we started doing transrectal biopsies is a little bit historic. Back in the day before ultrasound, the only way to really find a prostate lesion was with your finger. So they would stick a needle on their finger and then kind of guide it to the area blindly into the prostate. And so that sort of is kind of where the transrectal approach originated from. But the transperineal approach has a lower risk of an infection. And also, in most instances, no need for antibiotics. Also, there's a better cancer detection rate, particularly for sampling the top of the prostate, which the transrectal approach doesn't sample very well. And you can still do a fusion ultrasound biopsy, so it doesn't preclude that. It's well tolerated in the clinic. And also, when you offer both approaches to patients, they generally prefer the transperineal approach because, well, the risk of an infection is lower. The transrectal biopsies, as I was kind of alluding to, any chance of an infection is up to 7% and up to 3% chance of having a severe infection requiring going to the hospital. And that's even with antibiotics on board beforehand. And it's likely underreported because a lot of times people will get a biopsy with us and then go elsewhere, and that does not get recorded. We always think about multi-drug resistant bacteria, and that's another thing that Dr. Abuasli referred to. As we use more antibiotics, the bacteria get more resistant, and the rates can be as high as 20 to 30%. And so that's something that we got to think of as, clinicians is, are we doing what's right for potentially contributing to this problem? So that's another reason why the transperineal approach could be a potentially better approach moving forward. Large studies have shown the chance of sepsis, a severe infection, is as low as 0.7%. So that's something that is actually incredibly rare. Also, we also like to think of the other non-infectious complications of a transrectal biopsy, and things like bleeding, particularly rectal bleeding, can be present in as high as 30% of patients. And that's another advantage of the transperineal approach. There is no rectal bleeding chance because the needle doesn't go through the rectum. So that's another potential advantage. Transrectal prostate biopsies, as we were talking, miss the top of the prostate. And that's something that we can commonly see scenarios where people have had a negative prostate biopsy and their PSA continues to rise. And we think, oh man, did we miss the prostate cancer? Could it be hiding in the top of the prostate? And that's something that the transperineal approach samples better. Here's kind of a schematic showing the needle trajectory of a transrectal biopsy here on the left side of the screen, coming from the down and up and kind of missing sampling the top. But the transperineal kind of comes from a straight on angle and allows us to sample not only the cancer areas, which is usually in the backside, but also in the top as well, a little bit better. A lot of guidelines, particularly in Europe, but also coming to the US soon, is that the guidelines are changing to say that the transperineal approach is the preferred approach over the transrectal biopsies. And the American Urologic Association also shows that, well, if you really want to reduce your risk of an infection related to a prostate biopsy the most, you probably should just do the transperineal approach. You could do a rectal culture, which means putting a swab in your rectum and sending that to the lab, or you can get a whole bunch of antibiotics, and usually it's a combination of more than just one, up to two. But the transperineal approach kind of means that we don't have to do that as much. So who definitely needs a transperineal biopsy? Really those who are at a high risk of an infection, like immunosuppressed people, like with rheumatoid arthritis or ulcerative colitis, who are on medications that can suppress their immune system, people who've had recent antibiotics, prior biopsy infections or implants or joints, and also people who have suspicious tumors at the top of the prostate called the anterior zone. Also, people who have active rectal issues like hemorrhoids, it's another reason to potentially avoid the transrectal approach. Here at the Cleveland Clinic, we offer the transperineal biopsy at the main campus at the Hillcrest Hospital, and also coming soon to the west side as well. And that's something that Dr. Abuasli is leading, of setting up the transperineal approach on the west side. You can do fusion or non-fusion. And we do offer different types of anesthesia, the sedation, Pronox, which is the nitrous oxide, inhaled sedation, or just the local anesthesia, which most people tolerate just fine. Here's not obviously someone who's getting a prostate biopsy, but just showing this is the nitrous oxide inhaled minimal sedation. And what you do is you kind of breathe in and out through this tube. It kind of gives you a little bit of a dose of this nitrous oxide relaxation medication. It helps calm the nerves and is well tolerated. You can actually drive yourself. It kind of wears off right away. And that's something that we're offering more. So once we get a prostate biopsy, we get a pathology report. It takes about a week to get back. And it's kind of like difficult to interpret in most instances. Really, you can probably tell if something's cancer or not cancer. Well, it should say benign if there's no cancer present. But if there is cancer, we tend to assign a grade to it. Well, the pathologist will do that. And that's based on how aggressive the cancer looks under the microscope. And the grades that we give, well, the most common version of that is called the Gleason Score. But there's a newer version that's a little similar, more simpler to understand, but is similar, called the grade group. And that's based on how aggressive it looks. The higher the score, the more aggressive the cancer behaves. And also we look at how many of the cores are involved. So not only the number of cores that are positive for cancer, but also what percentage of the core is positive. So if 100% of the core is positive for cancer, then we know that the cancer is a little bit larger. So that gives us an idea of the volume of the disease. Then we also look for other higher risk patterns that the pathologist would recognize. One of them is called the cribiform pattern, and another one's called the intraductal pattern. And that's something that they will also be looking for. Here's kind of a pictorial of the Gleason score, whereas the small, less irregular glands are the lower risk type of cancer. And then as we get to a score of 5, that's where the cancer is more aggressive appearing and the glands are more irregular. And that's when it's more irregular, usually a sign of more aggressive cancer. It's kind of confusing and it's understandably difficult to interpret, because what you do is you look at the 2 most common patterns and then you add them together and then you get a number. There's a little bit easier way of doing things. One of them is called the grade group. So Gleason 6 cancer is grade group 1. So it's kind of why start the scale at 6 to 10. Instead, let's use the grade group, which is looking at a score of 1 to 5. And then you can take those grade group scores and kind of plug it into other types of parameters, like your PSA score, how your prostate felt, and you can assign a risk group based on the NCCN. And that kind of allows us to determine who can be a candidate for surveillance, just watching the cancer, or who is a good candidate for treatment. And there's, of course, a lot of different treatments that we're not going to cover today. But in general, the very low, the low, and some intermediate cancers can be watched. And that's kind of something that we will be using the pathology report from the biopsy to determine. Most intermediate, high, and very high risk patients would be candidates for treatment if you have a good life expectancy, because prostate cancer, it's a slow growing cancer. And so we like to know, well, what's your life expectancy? What's the likelihood that this is going to bother you in your lifetime? So the next step after we get the pathology report is we need to find out, is this cancer localized to the prostate? Or in rare instances, is this metastatic already? Has there been some spread outside of the prostate? The hope is it's localized, because then we have a good chance of curing the cancer if we need to treat it, or if it's a low risk cancer, just continue to watch it. So we do the staging, or finding out if it's localized, with a CT scan or an MRI that's looking for enlarged lymph nodes or spread to other organs, a bone scan. So it's usually an MRI or a bone scan that we use together to find out if it's localized, if it's a higher risk cancer. In certain higher risk cancers, we can use actually a PET scan. The most common that we're using now is called the PSMA. That's kind of a revolutionary new PET scan that's really very good for finding prostate cancer that has spread outside of the prostate. So this is what the bone scan looks like. It's kind of looking for suspicious bone lesions that could represent prostate cancer. And that's something that any spot, could potentially represent cancer. However, a lot of times people who've had prior fractures or arthritis could show up as a false positive. And here's kind of what a PET scan would look like, where they put a radio tracer in your IV, and then it attaches itself to prostate cancer cells and then lights up. So here's the top one, suspicious lymph node that's lighting up. And then the bottom image is where there's an area in your prostate that's lighting up. So that's something that's very sensitive and specific for metastatic prostate cancer. But it's not very useful in most cases of people with lower risk prostate cancers, but it is being used more commonly in people with high risk or very high risk prostate cancer if your insurance covers it. Unfortunately, sometimes we have to do a little bit of a battle with them to try to get it approved, but sometimes it may help us find out if you're a good candidate for local therapies. So let's talk a little bit about the future of diagnosis. Well, we expect more common use of PSMA PET imaging. There's actually types of fusion biopsies you can do where you actually do a biopsy using a PET scan instead of the MRI. I expect better use of biomarkers, so smarter biomarkers like the ISO-PSA, but also ones that are still being developed where we can do smarter screening, fewer false positives pretty much, and also finding ways to use biomarkers to avoid a biopsy altogether. Because what's the safest type of biopsy? Well, not having to do one. More and better genomic testing. We're looking at the genetics of the cancers more just to find out their behaviors, because that's the best predictor of how aggressive a cancer is. So we're getting better at doing that. And also using artificial intelligence tools to risk stratify people. Find out, is this the kind of cancer that you need to treat? Or is this the kind of cancer that maybe could just be watched? And also it can help radiologists and pathologists actually find the cancer themselves using artificial intelligence. We're using AI to spot your dog breed. So you can upload to an app, the picture of your dog, and it'll run a very fancy artificial intelligence algorithm to kind of find out exactly what type of dog you may have. Well, this same algorithm can be used to spot your prostate cancer. So here's an example on the left where you've got a core of the biopsy that is lighting up areas that are suspicious for prostate cancer. And here's an image on the right where it's actually comparing an algorithm that looks at prostate cancer and actually shows that it actually outperforms a lot of the pathologists. So this is kind of coming soon, not too soon, but it's on the forefront of where we use these as tools to help us kind of treat prostate cancer better. So what are my recommendations? Well, educate yourself. You are your best advocate. The more information, the better. And the better prepared you are to get your questions answered, the happier you'll be. And less treatment regret. That's something that we always worry about as urologists, is when people make the decision that they're not happy with. Beware of misinformation. It's everywhere, particularly related to cancer, and a lot of people overpromising and, saying, hey, buy this thing online, and it's some of these are actually dangerous, but at the very least it's not effective. So it's something that I would be very careful about, the sources of your information. Here at the Cleveland Clinic, we've got excellent sources on prostate cancer that you can educate yourself, and always get in touch with us if you want to talk more in an appointment. But there's also good support websites online. One is the Prostate Cancer Foundation. Another is Zero Cancer. Here are their websites. They have good patient information and also support groups, people who are going through the same types of things. A book I recommend that I think is actually very thorough but also easy to understand is Dr. Patrick Walsh's Guide to Surviving Prostate Cancer. Dr. Patrick Walsh is a legend in prostate cancer treatment. He's someone who has been updating this book, so it's up to date as well. And thank you. If you guys have, I guess, let me unshare my screen here. And I guess we can go to the next phase of answering everyone's questions.
Thank you so much, Dr. Schwen. That was a lot of great information. So we do have a lot of questions that Dr. Abuasli was stealthily answering during that presentation as well. Let's just go over the questions that have already been answered, and then after those, we'll go through some that have not yet been answered. So the first question was, given the FDA warning, is levofloxacin as a prophylactic antibiotic during prostate biopsy too risky? Is a mild antibiotic better? I'm very active. Tendonitis or tendon rupture would be very traumatic. And so to that point, Dr. Robles responded that there are alternatives that he considered, such as which is a different class of antibiotic than ciprofloxacin or levofloxacin can be used. It's done intramuscularly, so a shot through the, usually in the buttock. And we do typically use that as well for transrectal biopsies. But as Dr. Schwen and Dr. Abuasli mentioned, with the transperineal biopsy, there's a lot of times where we don't actually need to worry about antibiotics because we're not going through the rectum with a needle. The next question was, let's see, is the ISO-PSA a useful test following salvage radiation and ADT? And so this is after the treatment of prostate cancer, monitoring PSA levels to see if there's a recurrence. And so the answer to that for Dr. Abuasli is that the role is not clear. There is research being done, so we'll see what that shows. But again, this discussion was mostly for before you get a diagnosis or any treatment for prostate cancer. In that setting, ISO-PSA is very useful, as mentioned, particularly when you have a high PSA and don't know whether you should get biopsied again. Can the biopsy increase a PSA? Yes, biopsy can increase PSA for about 6 weeks afterwards. And then next question was, is the ISO-PSA test always used after a high PSA? And so here at the Cleveland Clinic, we do tend to use it a lot. It was developed in conjunction with the company in Cleveland. And so if the PSA is above 4, we can consider getting an ISO-PSA. But we do typically do biopsies without an ISO-PSA as well if there are concerning findings like a very high PSA or high PSA density, the other things that Dr. Schwen was mentioning, 4K score, PHI score as well. The next question, what are the risks of recurrence after 5 years? So again, this is after treatment, so not too relevant, but again, there's no one size fits all, depends on the stage grade, the surgery or radiation that you received. And so we'll probably get to those kinds of questions in our future talks as well. Next question, does the fact that I take finasteride mask any PSA results? This is a good question. Finasteride and dutasteride are medications. And as Dr. Abuasli mentioned, the answer that can decrease PSA by about 50%. This happens over a year of treatment using these medications. So after a year, we do double the number, the PSA number, to get the accurate PSA so we can trend it properly to get the PSA velocity like Dr. Schwen was mentioning. Do you take the same number of samples with both biopsy approaches? Dr. Abuasli answered this question as well, about 12 to 16 samples for both approaches. And that will
also, Paul, that'll also depend on if there's any targets, on the MRI, because we may add additional biopsies on any specific targets, and I'm sure Dr. Schwen would agree.
Right.
Yep, absolutely.
Right. And so from my understanding, typically if there is a target on the MRI, we usually sample about 3-4 samples from that specifically before we do the whole template kind of battleship type of sampling that we do as well. A very similar question afterwards that Dr. Schwen answered was there's only 12 samples using a small gauge needle on a 60-gram prostate that samples less than 1% or 0.5% of my prostate. How can that be useful? Presumably, aren't there many spots that you could be missing? So Dr. Schwen mentions that we use the MRI to help localize our biopsy cores, and so that MRI can find those targets. Sampling error is always an issue and was particularly an issue before the widespread use of MRI in the prostate. But the MRI has really helped out in finding targetable lesions that we can then put needles into. So that was a great question as well.
That's a great question. We always think about sampling error. It's something that's why we never use one tool. We usually use a combination of tools: PSA, the exam, the MRI. And if something's not adding up, like if the PSA is going up still despite a negative biopsy, then we think, oh, could there be a sampling error? But the MRI has really helped that.
Perfect. We do have a couple questions. Let's go through these. There are a couple questions as well about diet. Maybe we can address those at the end as well, but just going through. This question is, I'm 65 years old with two brothers with prostate cancer. So there's a family history. One actually passed away from prostate cancer. My PSA was low, 1.2. And then this year, and then 2 years later, it went up to 2.8 with an enlarged prostate as well. My general practitioner says wait and maybe do another PSA in 6 months. So maybe Dr. Abuasli, if you could weigh in on this.
Yeah, I think the number by itself in isolation is not concerning for a 65-year-old, but a couple factors which can increase our suspicion or concern are the fact that he had two brothers with prostate cancer, and it may be important to know what age they were at diagnosis and whether they had high-grade disease or grade 1 prostate cancer. But also the PSA velocity, so the change over time is a little concerning. So this is someone that I would discuss the pros and cons and maybe consider either a full MRI, or we have at the Cleveland Clinic a screening MRI, which is what we call limited MRI, which is less costly, but also gives us almost as much information as the traditional MRI. So if someone really wants to know, I think the limited MRI may be a good tool in this situation, and then a biopsy if there's a lesion.
Perfect.
Ziad, what do you think?
Yeah, I agree with that completely. I think that rate certainly is worth looking at a little bit closer, either with repeating it or getting additional imaging. But with your family history being like it is, I think it's important to take that seriously. So I think it's hard to kind of answer that question also without doing an exam or talking to you a little bit more. So I think it's a good idea to just see a urologist, one of us, or anybody here at the Cleveland Clinic. There's a lot of excellent urologists here.
Agreed.
Very good point. Great question here. Can bike riding affect PSA? If yes, how long should you stay off the bike before a test? So let's, Dr. Schwen, who rides bikes frequently, let's have you answer this one.
Yeah, so there are times where certain activities can cause a transient rise in your PSA. Sexual activity is one of them. Bike riding can be one of them as well. It's putting a lot of pressure on your prostate. I would say hold off on it for 48 hours beforehand, just because, well, you don't want to get a falsely elevated thing. But for the most part, it's probably a minimal benefit, minimal rise. Other things that can cause PSA to rise: recent infections, like in the urinary tract, or even viral infections. But it's something that, that's why PSA by itself is a good screening test, but is not a great kind of specific, indication for whether or not you need a biopsy. But it's a good idea to kind of reduce those potential false positives.
Great. And then next question. Will hormone therapy affect PSA values? Great question. Dr. Abuasli.
Yeah, it certainly will. Of course, it depends on what hormones you're specifically referring to. But if you're talking about testosterone, like for example, if you're getting treatment for prostate cancer and you're getting a medication which lowers your testosterone, you would expect the PSA to decrease as well. If you're getting testosterone replacement, for example, for another reason, that can increase your PSA as well. So that's something you want to take into account when you're considering testosterone replacement.
Yep, no, I agree with that. Paul, do you want to also talk about the diet thing? I think that's
Yes.
that's a very common question I get in the clinic about certain things that you can do from a dietary standpoint. And Dr. Abuasli, you can also chime in if you have other specific recommendations. There's not a lot of excellent evidence, but there are some studies that do suggest certain trends, like red meats are certain things that can be associated with developing prostate cancer, but also an enlarged prostate in general. But eating a lot of red meat could potentially be associated with that. High fat, high cholesterol diets and obesity are certain things that also can be sometimes associated in certain studies with developing prostate cancer. In general, things that can help are a lot of plant-based diets. Certain types of vegetables can be shown to be, beneficial in terms of reducing your risk of prostate cancer, like broccoli and cauliflower. There are a few other studies out there that looked at tomato and also coffee being things that are technically associated with a lower risk of prostate cancer. Rob, what do you tell your patients when they ask you that question?
Very similar thing. So, like you said, the evidence is not strong because a lot of these studies that have looked at diet are epidemiologic studies. So what that means is they look at the risk of prostate cancer in a specific region and the types of diet that people tend to eat in that region. So Eastern diets, people in Eastern Asia and so on tend to have lower risk of prostate cancer. So, and their diets tend to be higher in vegetables and lower in red meat. Whereas in North America, it's the other way around. We don't have really any studies that have shown that if you feed someone vegetables that their risk of prostate cancer will be lower. But again, these epidemiologic studies tend to suggest that. And like you said, red meat is the big one. And basically, a lot of the things we see in North American diet, such as excess dairy and cheeses and so on.
We're actually doing a study here at the Cleveland Clinic looking at diets and people who have prostate cancer on active surveillance. So that's something that a lot of people are studying, and it's an important question. It's hard to find specific, diets because it's hard to control for them. But this is actually one of the studies that actually is going to be very strictly controlling the diet. So hopefully we can get some answers.
And what I typically end with is, what's good for your heart's good for your prostate. So if you eat a heart healthy diet, you're going to live a long time, and that's going to be good for you and your
Great point.
prostate. So
That's an excellent point. Yeah.
Right, great. Maybe just because a couple more questions, and then maybe we can wrap it up. But the next one was, how do you go about monitoring the finding of ASAP? And so you've undergone a prostate biopsy, you've gotten the results back. It's not benign, it's not cancer. It's this weird thing called ASAP, or atypical small acinar proliferation. How do you go about explaining this to your patients, and what are the next steps?
yeah, I mean, I'm happy to start. So, the ASAP, we know older studies have shown that your risk of subsequent prostate cancer is about 40% if you're going to have a repeat biopsy. But, now we know that most of those tend to be grade 1 prostate cancers, the ones that are on active surveillance and so on. So the old recommendation was everyone would get a repeat biopsy about 6 months after your diagnosis of atypical glands. Now I just tend to put it into context. I may consider, again, if they haven't had an MRI, I'd consider an MRI, see if there's a lesion, and just assess the risk. And, it is a risk factor for prostate cancer, mostly for low-grade prostate cancer, but we want to make sure we're not missing any high-grade cancers. So at some point, we may consider a biopsy, especially if there's a lesion on the MRI.
Yeah, I totally echo that. I think that's something that as our understanding of which cancers we can safely watch evolves, our understanding of kind of these other findings like ASAP also kind of evolves. And so before we used to be pretty aggressive and rebiopsying everybody, like Dr. Abuasli said. I do similar things. I'll usually see a repeat biopsy, a repeat PSA, and if they haven't had an MRI, I'll get an MRI just to make sure we're not missing anything. And only if anything else is kind of making me concerning, like the trend of their PSA or a suspicious lesion on their MRI, will I typically recommend a repeat biopsy, but it's very patient dependent and individualized decision. So that's something that it's important to just be aware of and know that someone's watching it.
Awesome, thank you. And then I think a good question to end on is, when should I stop getting a PSA in digital rectal exam? I'm 76, I'm in very good health. My PSA is low, but it's slowly increased to 1.9. What would you recommend for this gentleman? Maybe
Yep.
Dr. Abuasli.
Okay, yeah. So, I mean, again, as I showed some of the recommendations. Most organizations don't recommend screening over the age of 70. That being said, I think, again, it's an individual decision between you and your physician. Talk about the pros and cons. And if you're in very good health and you have more than a 10 to 15-year expected life expectancy, then there may be some benefit, but your PSA is pretty low. So you may want to talk about whether it's time to discontinue PSA screening, particularly if you have no other risk factors, no family history, or any other risk factors for prostate cancer.
Yeah, I echo that statement. In general, it is an individual decision, but also a shared decision, with your urologist. They'll kind of talk to you about, yeah, what's your life expectancy, but also what's your level of concern, but screening can also lead to more concern and more worry, especially if there's a low likelihood that you would ever be diagnosed with prostate cancer, because there are a lot of false positives, and there are risks to doing biopsies and additional testing. So it's something that, you have to just weigh what is your preference when you're aware of the risks and the benefits of continuing to screen. Usually we would have a higher threshold as you get above in your 70s, and to do a biopsy, and also to consider treatment if we do find prostate cancer. But it is important to just kind of make that decision yourself.
Great, thank you. I think that wraps up our discussion today. Thank you to Dr. Schwen and Dr. Abuasli again for taking the time to educate us, answering such great questions from our participants. Again, this was recorded. It will be available, I believe, in about 1 week. If you have any desire to rewatch it and to go over some more slides as well. And then our urology office can always be contacted if you'd like to make an appointment, have any questions. You can always request one of our fine experts today as well. So again, Dr. Schwen is at main campus at Hillcrest Hospital. Dr. Abuasli is at Fairview on the west side. And so anything else from our panel, from our speakers today before we wrap it up?
No, thank you very much for moderating. I think this was a great session, and I really enjoyed it.
Thanks, Dr. O, and thanks everybody else for tuning in.